there is evidence that maintenance lenalidomide actually does improve disease progression. It reduces it. Now, survival data, however, in the setting of multiple myeloma have been mixed. Some studies report improved overall survival, but others show absolutely no benefit with this approach. So we are here to discuss a large randomized controlled trial for newly diagnosed symptomatic myeloma patients of all ages that includes a maintenance comparison of lenalidomide versus no maintenance. And to talk about the study, I'm here with Professor Graham Jackson, who's an MD of Newcastle Hospitals. He's a professor of clinical hematology at Newcastle University, Newcastle upon Tyne in northeast England. Now, this has been a topic of some debate in recent years, hasn't it?
It certainly has. It's one of those areas where there has been some controversy. And so I think one of the great things about our study is hopefully we can finally define the role of Revlimid in the maintenance setting across all patients with myeloma.
That would be really nice. Now, this is the phase III Myeloma XI study?
That's correct.
So describe the study first off.
Okay, so this is a large randomized trial carried out in over 100 centers in the UK. Recruiting over 4,000 patients, asking a number of questions. But the question we're here to talk about today is the randomization of Revlimid versus no maintenance in both the transplant-eligible population and the transplant-ineligible population. So we're reporting this afternoon on 850 patients treated with maintenance, 450 in the transplant-eligible arm, and 400 plus in the transplant-ineligible patients.
Now that's a fairly sizable group, and more than what's been evaluated before, correct?
It is. It's the largest ever study, I think, ever carried out in newly diagnosed multiple myeloma. So with that many patients, I think you can really definitively answer a number of questions.
So what are you finding?
So our findings interdigitate really nicely with a meta-analysis that was produced at ASCO this year.
I remember that.
So at ASCO this year, Michel et al. Presented a meta-analysis of Revlimid maintenance, showing that clearly in the transplant-eligible population, Revlimid maintenance has a significant effect on progression-free survival. So in our study, across all patients, 850 patients, there's an improvement of PFS of 18 months. In the transplant-eligible patients, that improvement was 22 months. And even for the elderly, frail patients, the improvement in progression-free survival was 13 months, and all with a very significant hazard ratio. So I think really showing that Revlimid maintenance in all patients is effective.
Now, in your study, about 132 patients, I think, stopped their maintenance therapy, including about 90 for toxicity. What toxicities did you see?
Okay, so that's a really interesting question, isn't it, in the maintenance setting when patients are well.
Exactly.
So you don't want to burden them with a lot of side effects. The main side effects of Revlimid maintenance are hematological toxicity, and the real thing that you have to watch out is for neutropenia. So we saw around about 35 grade 3, grade 4 toxicities, and so clearly that is the major issue. Anemia, thrombocytopenia, neuropathy, VTE, not a major issue. So you have to learn how to manage to keep the patients on maintenance. One of the interesting bits of data that we're really going to drill down on in the next year or so is the fact that the patients who stay on Revlimid longer seem to do better in terms of their progression-free survival. So this is patients who either stop for toxicity or for doctor-patient discussions, and the longer you stay on the maintenance, the better you seem to do.
What was kind of the minimum that they needed to be on to show benefit?
So this is very preliminary data, and obviously I don't want to overemphasize it, but it would seem that patients stopping earlier than 1 year because of reasons other than progression did less well than patients who stayed on maintenance for longer than a year. And we're going to analyze that data over the next year to really drill down on that duration of maintenance issue.
And because you had so many patients, as you went along, did you get better at managing toxicities and recognizing a patient that needed attention?
I think we did. I think, as you say, 100 patients stopped their maintenance because of toxicity or other decisions. Out of a trial of 800-900 patients, that's actually a small dropout rate for a maintenance strategy. So I think we did, and I think certainly in the UK, the trialists felt very comfortable with keeping people on Revlimid and adjusting the dose to the patient they had in front of them.
At this point, would you say lenalidomide maintenance can now be considered a standard of care for people with multiple myeloma, or do we need to know more else first?
Listen, I think this answers the question. We've got Michel et al.'s beautiful meta-analysis of 3 trials. So our data is almost as big as the meta-analysis, and it really complements Michel's data really nicely. So our results in the transplant-eligible population almost mirror the meta-analysis. And our transplant-ineligible data kind of mirrors the first data, which is Revlimid and dexamethasone to first relapse in the elderly population. So I would say the answer is yes, we have really nailed this question.
So you're still looking at different questions, and there are still things you want to find out from the data.
Yes.
But at this point, you think this is a good idea?
Oh, for sure.
Well, thank you very much, and I congratulate you on this, because this has been an issue of some debate, and it's really nice to get some final answers, I would imagine.
It's really nice to provide the final answers.
Exactly. From ASH 2016, please look online as well as in print at ASH Clinical News. I'm Rick McGuire.